Good. So I'm from a small island, Antigua and Barbuda, and we have 100,000 population, just giving you a scenario. With one public hospital, all our trauma comes to this hospital and it's done by general surgeons. We have no trauma surgeons. Can everybody hear me?
Yes.
Yes.
Okay. I have no disclosures. And the learning objectives here, it's going to be a case of a gunshot wound to the neck. It's an atypical trajectory, and we want to, if we should trust the evidence, there's been no real consensus internationally on guidelines for penetrating neck trauma. And so I think it's a traditional zonal approach, and I think this is what we could review today. So the objectives, we want to recognize the challenges of managing cases in a low resource center, underlining the importance of trust in the evidence, and we want to talk a bit about wound ballistics. So in my case, I have a 25-year-old patient who is rushed to the ER after receiving a single gunshot wound to the left side of neck. All the vitals are normal. The symptoms are pain to the gunshot wound site with minimal bleeding, minimal swelling, and he's conscious, oriented, minimal complaints, and he's seen in the ER by the ER doctor in the trauma bay. A, B, C, D, E, nothing very important. He seems calm and comfortable, and this is the picture of the patient.
All right, any questions so far from our panelists? Dr. Martinez, Dr. Sutori, Dr. Diaz?
No specific question, but where we are so far, and there's a comment, in the case presentation, I think it highlights the changes in paradigm where previously we've always had a zoned approach to management of penetrating neck trauma, specifically ballistic penetrating neck trauma, which as Dr. George alluded to, there is no international consensus guidelines, especially for low or middle income resource countries where all the specialists that we might be accustomed to at level 1 trauma centers in the United States might not be available. So I think this case, as it's currently developing, does highlight the selective no-zone approach that more is specifically guided by the patient's clinical signs and what you're concerned about with the anatomical location of the injury.
I have only a simple question. So this is the only one wound what we can see. So we found the entry point, but we suspect the bullet should be inside somewhere in this soft tissues, isn't it?
This is the only entry wound. No exit wound is found. Patient is examined completely. No other injuries. Minimal bleeding from this wound. That's cleaned. Slightly swollen and tender. Minimal, very minimal subcutaneous emphysema.
What can we hear if we use our stethoscope at the chest wall or in the neck area? So something not normal sounds or the air movement sounds
air entry is
like
normal.
normal breathing. Yes.
Air entry normal bilaterally, and all vessels, the carotid, pulses, everything else is normal.
Dr. Diaz?
So when this patient rolls in, and this is just more of an approach, as Dr. Quinones mentioned, we previously, for those who were trained back in the last millennium, we were rather regimented in terms of the neck injury level and the workup and the approach. It is also always important to make sure that you are not identifying any hard signs of either hemorrhage or aerodigestive tract injury, which immediately would take you to potentially the operating room, either for hemorrhage control or for airway management. So no active bleeding, no expanding hematoma, no major subQ, or the patient not, expectorating or throwing out blood, all signs of hard signs of a potential vascular or an aerodigestive tract injury. In the era where I was trained, this is below the cricoid. So that would be a zone 1. So depending on the circumstances, might require further investigation for concern that there may be an injury that might not be accessible short of a median sternotomy. But today there are imaging techniques where you could potentially decide whether or not you might need further imaging, or maybe patient may benefit from directly going to the operating room, again, depending on whether or not the patient presents with hard signs of an injury. So can you provide us with, you mentioned that you didn't find any expanding hematoma. There may have been some
No hard
prejudice,
signs,
but was he coughing up any blood? Was there
no
any stridor or
hemoptysis, no
anything like that?
hematomesis. No hemoptysis, no hematomesis.
All right, Dr. George, can you go
Yes?
ahead, please? Yeah.
Okay. So what would be the next step?
Those are the tricky cases, right?
Yes, yes. So, okay, so your next steps, I was wondering if they would. Well, this is what was done for him in the ER. He had an x-ray done first of the neck and then an x-ray of chest in the ER. And if we notice that the bullet has passed the midline, it's on the, well, okay, I'll leave it here. This is the bullet. Chest x-ray and neck x-ray.
I don't think we've asked this, but was the projectile palpable on physical exam?
Not palpable on physical examination.
Yeah, the point is the entry point is on the left side, but now the bullet is on the right side, so
Yes.
it crossed the neck.
Yes.
Is it possible to do an ultrasound or a CT scan? Because our patient is stable after the primary survey, is talking, no major bleeding, so no ABC problem. So in this case, if it's possible, I suggest to go to the CT scan or to perform an ultrasound, if it's available, of course. So it's different from the local situations.
There is no
Have you-
ultrasound available in the ER.
And CT scan?
Yes, there's CT scan available.
Have you done it?
Okay.
Can I ask a quick question of our experts here? Anybody would intubate this patient right off the bat before you go get further imaging?
Not without the patient coughing up blood or having any stridor, on exam, making sure that there isn't any deviation of the trachea. I think those would be findings where I would be concerned that there could be airway compromise. But without that, I don't see an indication for intubating the patient at this point.
Yes,
Yeah,
I
like-
agree. So
I agree.
yeah, I agree, Jose. So if there's no indication, it's not the best thing to do it before the CT scan.
Yeah,
Only
I
if
guess
you have some ABC compromised situations.
Yeah.
I guess it also depends on the architecture of your hospital. Some hospitals in Brazil, the CT scan can be far away from the trauma base. So maybe it's a good idea to protect the airway. Depends on your settings.
So we move with this patient to the CT scan, of course, with the view that if he deteriorates, we may have to intubate. But at that point, he did not. I'll just for this first CT, if you can see, I think I have a better image. Let's see. And I think this one shows it, that it went directly across the line. So we've done the CT scan. And what would you do next here?
All right, Dr. Diaz.
So on the scan, at least as far as I can tell on the images I'm seeing, I don't see a vascular injury. You do see air around the vessels on the left, around the carotid and the IJ. And it appears to run a track that would be posterior, and you do see what looks like a small clip of one of the vertebral bodies. I didn't get a chance to count which one. And then the missile is on the right side, and you see a little bit of air around the vessels on the right. So it does appear to have missed the trachea, but under this view, I cannot tell whether or not it injured or did not injure the esophagus. And as we know, the esophagus runs right along the posterior aspect, right in front of the spine. And so I can't imagine that it went posterior enough where it completely missed the esophagus. I think your next plan would have to be an EGD in the operating room.
Dr. Martinez.
I agree. Because as Dr. Diaz alluded, with the degree of air in the soft tissues, the patient's airway being, as of right now, protected, no crepitus, no voice changes, most likely you still need to exclude digestive injury, which in most settings would be either rigid or flexible endoscopy. I know there's some literature and some centers are doing more selective non-operative management with contrasted esophagograms akin to perforation, other workups, but that is limited to very specific centers.
Dr. Sutori.
Yeah, I live in a different world because in Europe we mostly have blunt traumas. So a neck gunshot wound is rare in my practice and in my hospital. But I would like to know two things. First, is it correct that we only have soft tissue damage and we don't want to operate the trachea and the esophageal? And if we have opportunity to check it from inside, so do a fibroscopic or an esophagoscopic, it's and also a double check procedure to secure us, okay, we have only to do soft tissue management, and from a small incision, a small exposure, it's enough to remove the bullet. Or sometimes it could be tricky because I had patients who had small esophageal lesion, but it wasn't possible to recognize on the CT scan. So if we have time and the patient is stable, my suggestion is to plan the surgical approach and try to use these methods.
All right, it seems the patient is cooperating, so we have time to think and plan ahead. What have you done, Dr. George, please?
Can I interrupt 1 second? I think Dr. Pasquale asks a very interesting question on the chat. This was not a CTA, correct?
Oh, I'm sorry, I missed that.
No.
And so do we, to our experts, do we think we've officially ruled out any arterial injury based on that CT with IV contrast? Or would you put the patient through a dedicated CTA, also looking, I presume, for not only obviously an injury to the vessels, direct injury, but also maybe a blunt cerebrovascular injury from the kinetic energy of the missile?
If available, yes, the CTA with proper triple face for arterial and venous injuries, as in the interim, as you mentioned, also looking for blunt cerebrovascular injury. And there's another question in the chat: is why not CTA? Is it something that it's not available, or are there any reasons to?
So at that point in time, after doing the first CT and physical exam, we opted to wait because it seemed like there was no vascular injury clinically. And I should mention also, we don't have scopes for this patient, so we could not scope this patient. And the patient refused to have any other test done at that point in time. So here we're concerned, I was more concerned of a missed esophageal injury, more so than clinically, more so than anything else, and thought that this patient might need to be explored.
My only
Right, so
comment,
it's a,
if I could add
Go
just
ahead,
a
please.
comment, clearly today that patient would have gotten a CTA. It's only because that's what we typically use for screening someone for that kind of injury. If you go back maybe 10, 15 years ago when we did not have CTA, the CT scan with contrast still would pick up over 90% of vascular injuries. May not necessarily provide you with the fine detail we have today. And if you did a venous phase, you would also see the venous injury as well in the previous scans. But you know, if you're asking what do we do today? Today we get a CTA with a venous component.
Okay. So this is what we did. And this patient was discharged after 3 days and did quite well. And this left us wondering, and I'm not sure if anybody could comment regarding the ballistics and why this could have happened.
Anyone? Dr. Sutori? Can comment on that? I believe we got some fingers crossed and it works all right. So what's your thoughts?
Yeah. So the question is, what was the projectile way it hit by the vertebrae? So, and that was what can stop and modify the direction. If you can see on the on this yellow line. Yeah. I'm not sure, and always is in question in my brain. Okay, there was no sign for an esophageal injury, but I thought that high energy can destroy the wall of the esophageal, so I'm not able to be enough calm and just discharge the patient without any specific examination, looking at the CT scan, because it was super close to the esophageal structures, and if the bullet can transfer the energy to the esophageal wall, it can destroy it and can cause a latent ischemia, and maybe later on it can develop the lesion. So we need to re-examine. That's my opinion. We need to re-examine the patient, and if it's possible to check the esophageal structure, looking in the CT scan and thinking about the bullet way and the energy transfer. But of course, you should know we live in a blunt trauma area, not in a penetrating gun area.
There's a question in the chat, and I'm going to add afterwards. Two comments from the chat. One, why did you not get an upper GI contrast study to rule out esophageal injury or a potential?
Yes, oh, we did that, but the contrast, we don't have a barium swallow because we don't have fluoroscopy outside. So that wasn't useful after we put the contrast in. We couldn't get the scan didn't, the contrast was passed before the scan was done because it's so high. So we gave some contrast, and there was no extravasation of contrast in the neck, and we couldn't even pick it up when it was done.
Dr. Diaz?
I mean, I think this kind of falls into the same type of scenario as penetrating injury to the abdomen, where you have just too many patients to go operate on everybody. And I think that, you can convince yourself that this patient doesn't have an overt injury that requires emergent operation, but you're going to observe them to see whether or not they get worse. Very similarly to the patient who may be seen in either South Africa or South America with a low velocity injury, This probably is a 22 caliber. 22 caliber usually, you know, has 600 foot per square inch velocity, so it's not going to have a big cavitating effect and may not necessarily cause additional injuries without just a kinetic injury with the bullet. So if you observe them over time and they get worse, then you take them to the operating room, knowing that by the time they manifest, their outcome may be worse, but that's what you decide to accept. So that's one option on how you can manage some of these patients. If you happen to have the luxury of having all the resources as we've described, then yes, these patients typically may get the triple workup that they used to get, or at least, you know, a bronchoscopy and esophagoscopy, or maybe a barium swallow to make sure. You still have to look, because sometimes you may have an intact esophagus during the initial evaluation, but you may actually have an area of ischemia that doesn't manifest for 24 or 48 hours. You know, there are different options that you can follow based on the injury or the suspected injury. You just have to decide on what complication you're going to accept.
Yeah, and one more thing from my side. So if it's possible to use methylene blue, we can see to come out or not using the soft tissue drainage, or if you don't have the poppy seeds, the small black poppy seeds could be enough, like a biological indicator. It's an extremely old technique, but if you don't have any specific imaging contrast or color contrast, it could work. I had a case when we didn't found the injury before we didn't use the poppy seeds. So it can be a good but really old indicator system.
Yeah, and I think just to bring it back to two things that Dr. Diaz mentioned, having the luxury of knowing the projectile or the foreign body that caused the injury is quite important. Unfortunately, here in the United States, we see more and more high velocity projectile injury more often. In knowing not only the size of the projectile, but also what type of projectile it is. And what I mean is, when we talk about these bullets, is it a fully integrated casing? Is it a hollow point, meaning the opening of the bullet is open, so it will actually cause more tissue injury? Or if it's one of these new projectiles that actually breaks into 7 or even 12 different pieces as it hits the tissue or it's the target. So those will be a lot more destructive. So the kinetic injury, the blast injury effect, and the actual tissue injury will vary according not only the size, the velocity, but the type of projectile that's being used. So in settings that you don't have as much resources when it comes to immediate imaging, angiography, or even subspecialists having the potential luxury of knowing what caused the injury could then guide you one way or the other for the potential management. And then the last question that I had is, we talked about this observation, and I know this can be potentially controversial, but during this observation period, what was the nutritional status of the patient, and were there any antibiotics being used?
Yes, so he had IV antibiotics. We had cephalosporin, and he had the first 24 hours he was left NPO, and for next day he started with a diet. So he had liquid diet. There was no trouble at all, and he left on liquid diet. We saw him he left after the 3rd day. We saw him just about 4 days after, continued his diet, and he was fine.
Great. Don't you think that this patient, he did not require extensive resources? Could such resources be made available at another hospital? Do you think of that, or maybe transfer him to?
Right. So there's one private hospital that has EGD, and we thought of doing that. I think this was a long weekend. This was This was a Saturday morning, yes. So we thought of doing that, and we could not get him to pay for that test. So at a
Okay.
private hospital, you'd have to pay to get an EGD, and at the public hospital, there's no charge. So the patient said he was fine and he did not want to get anything else done. And that's why
All right.
yes, but we thought
Yeah,
about
yeah.
it practically.
And I got a question for our panelists. Since we talk about the energy of the trauma, if this had been a stab wound, would be management differently? Since it's a low energy injury, you manage different if it was a stab wound?
I would say that I think you can manage it similarly. Again, you can penetrate, you can have an injury to the esophagus with the same course, not just, not just here you are concerned not only that you have a potential penetrating injury to the esophagus with the bullet, but also from the kinetic injury that might be delayed. Also, similarly, in a penetrating injury from a stab wound, you can have an injury to the esophagus that is either manifests immediately, and occasionally I've seen in rare circumstances where it could be delayed. And so if you are resource trapped, I think you do something very similarly where you can decide whether or not you need antibiotics. Some people might say, well, if you put them on antibiotics, that might delay the presentation because you might mask an infection. But then there's maybe some others who would say, well, if there is an injury there, then I'm already prophylaxing the potential injury. So it's a little bit of a double-edged sword in that perspective. But yes, there is, I think, reasonable to manage a stab wound to the neck in a similar manner.
All right. We have 30 minutes now. We have to close this first presentation. I would like to thank our presenter and our panelists for preparing today's discussion so far. And we are heading for the second presentation. Thank you all.
All right, thank you, everybody. That was great. We'll move on to our second case presented by Dr. Chung from Hartford Hospital, University of Connecticut. Dr. Chung, the floor is yours.
Hi, thank you all so much for having me. So today, see if I can keep going here. I have no disclosures. So here's our case. We have a 24-year-old female ejected from a vehicle during an MVC with a left lower extremity amputation. That was the report that we got. And so she was presented to our hospital as a full trauma. On primary survey, she initially had an intact airway. However, she was shortly after presentation intubated. Just given the fact that we'll go through it later in her presentation, essentially for airway protection and then future interventions that she would need. She had bilateral breath sounds that were clear on arrival. She was tachycardic, hypotensive, with diminished radial and femoral pulses. She also had a right subclavian cordis placed, and we placed a tourniquet in her, and she had a left thigh tourniquet in place on arrival. Initially, her GCS was 14 on arrival, and her motor and sensation was intact in her upper extremities. And she was noted to have an unstable pelvis. When she was all exposed, we did notice the left below knee amputation with gross contamination. She had an obvious deformity of her right lower extremity, extensive soft tissue avulsion injury to the right gluteal and inguinal regions with gross contamination. And I have...
Dr. Chung, I'm going to pause you here for a second. I am curious to hear our experts' thoughts on, there is a push from certain institutions for direct to the operating room, and patients that from the field are probably going to require intervention. Obviously, this is a traumatic amputation in the field. You're going to have to do something. Any role you think we are overdoing it, underdoing it? What are your thoughts on that? I'll start with Dr. Martinez.
So I do think there is a role, and I'm gonna draw from my fellowship days at University of Pennsylvania, which were not too far away, or a year-ish ago, because we did have a direct to OR policy. In that specific scenario, because we did have a high rate of penetrating injury patients, we would have the attending meet the patient, meaning whether they were coming via helicopter or directly through ground transportation, we would make sure that the patient had pulses and that it's not a patient that would actually code or were currently under cardiac arrest. If we had pulses, then we would proceed directly to the operating room. So it's something that certainly requires an entire team approach. It is doable. We have something similar at my current institution. We don't have a true direct to OR policy, but we do get a lot of transfers from rural North Carolina. So when we know what the injuries are coming and that the patient will need an intervention, we will speak with our operating room to have everything ready. And as soon as the patient is in the system with a medical record number, we start getting ready. So the patient spends ideally less than 5-10 minutes total from arrival to making it to the operating room. So I do think.
Dr. Satori, sorry, in Hungary, is that something you guys are looking at or doing, or is that something that is unique to this side of the world?
Yeah, it's a known fact. We need to go to the OR after the dramatic amputation. My question is it a controllable bleeding? So he lost the amount of bleed on the scene from the extremity, or does she have an uncontrollable bleeding, for instance, thanks to the unstable pelvic fracture or another injuries? So in Hungary, the system is a little bit different than in the United States. So it's not possible to get a quick CT scan, and I don't want to have a quick CT scan because she's in shock and she's maybe bleeding, maybe not, but we have ultrasound in every case, and I like to do it by myself, and it's super fast to check and do an e-fast. So I would like to check the thorax and the abdomen, is bleeding or not. If it's not, it's a controllable bleeding because we have tourniquets 1 or 2 on. So in this case, we have time to start the hemorrhagic management before the operation, because in the first 30 minutes, not the surgical intervention is the most important thing. So I would like to start to solve the hemostatic problem. On the other hand, if we have a continued bleeding patient, we need to go to the OR and start the surgical procedure with this. For instance, if the pelvic is unstable and is bleeding, we need to pack it and after think about the extremities. So that's our daily practice.
Dr. Diaz, my question to you is, do you pull out the Reboa or do you hold off? What are your thoughts on this based on this patient?
I probably would pull out the Reboa in this scenario. I think that in blunt trauma, as opposed to penetrating trauma, the go to the OR is much more challenging because that means that you have to bring then an X-ray or C-arm into the operating room for radiographic assessment of the patient. It's easily to quickly look at the thoracic cavities and the abdominal cavity looking for bleeding, but if you have an unstable pelvis and you need to be able to stabilize that, or in this scenario where you have an open groin, you're going to need to get vascular control quickly. And the fastest way to do that is probably to use the Reboa in this scenario. So I do think that this patient probably needs a tourniquet on their right lower extremity, or that's the correct one, right? Yeah, or sorry, left lower extremity. If you can. If it's in the groin, then you're going to have to just assign someone to hold pressure until you can get control at the bifurcation with a Reboa in this situation.
Dr. Chung, share with us what you guys did.
Sure. So moving forward, these are just some pictures of what we encountered, unfortunately, when she was at our facilities. So as you can see, the traumatic left lower extremity amputation, grossly contaminated, and the incredibly extensive soft tissue injury she had to her right perineal region as well as the gluteal region. So we initiated MTP and placed a pelvic binder. As you can see there, our initial chest and pelvis x-rays and her shattered pelvis on the left side. We did perform an EFAST, which was negative. And then you can see before we even made it out of the trauma bay, she received 2 units of whole blood, 6 PRBC, 6 FFP, and was and 1 pack of platelets, and she was still hypotensive. So
All
then
right,
at this,
Dr. Satori, can I just pause you for a second? Now you have your chest x-ray and it looks like your FAST is negative, so you assume nothing really major going on chest and abdomen, right? Seems like she's obviously under MTP. Go up to the operating room. Anything you would do differently? I know Dr. Diaz mentioned you need a C-arm. I know some facilities have obviously the hybrid room. Thoughts on how you would proceed from this point on?
In the same way. So it would have been the same to started the fluid and the blood resuscitation in parallel of this. I would like to do some imaging, because if I see this AP pelvic X-ray, it's not a simple fracture. So it's a C3 type, and it's not easy to stabilize it with a pelvic blinder, because it can hold the position, but that position is not correct. So I would like to know, and the best way would be to have a CTA, because I'm interested in the iliac artery and vein. Maybe it can compromised, or can be a laceration, and it require a different management. So I don't start with the pelvic axis and the anti-shock screw in this situation, because I would like to finish the amputation, would like to care the vessel structures, and after think about how to stabilize. So for summary, after the fluid and blood resuscitation, I need more imaging, because I need a plan.
I agree with Dr. Satori, but I do have additional question, because you mentioned at the beginning that patient initially was responding but had to be intubated. So with everything that you've mentioned, what was the sequence of events, and when was it that the patient needed intubation? Was it pre-blood product resuscitation? Was she a non-responder and require intubation? Because then that would dictate the next steps. If she's not responding, required intubation, then we should either be in the operating room, or I do not have REBOA at my current institution, but this would be a case to place one. So that will, the divergent clinical decision-making is hinging on her intubation status, or what required her intubation and her response to resuscitation.
yeah, so her mental status was waxing and waning throughout her time in the trauma bay, mostly in relation to her hemorrhage. So we were able to get her to transiently respond enough to get a blood pressure, at which point we intubated her. She didn't have any active hemorrhage in terms of her left lower extremity traumatic amputation with a tourniquet up. And then since we were able to get her stable enough for intubation, we took that time to do it. From that, and then of course she was only a transient responder, so we then in this case went to the operating room immediately, to our hybrid room is where we went.
Dr. Diaz, any concern getting arterial access for REBOA here in a pelvis where clearly there's a lot going on?
Obviously, there is a challenge. So yes, well, today almost every trainee is trained for ultrasound. So it's probably the scenario where as soon as you get a pulse back to using ultrasound guidance to go ahead and cannulate the left, or I guess the opposite injury. So left, or because the picture looked like it was right lower extremity, but whatever the opposite extremity would be, to get arterial access to be able to get the REBOA in place. And if you can't do that, then obviously the next step is to do a cut down.
Dr. Satori, are you happy with it? I know you wanted more information, but in a patient that's unstable, who doesn't seem like we're getting enough of a responder to be able to get them imaged, would you just continue your resuscitative efforts until you can get them to a better place and get them to imaging studies? Or at this point, do you just go ahead and proceed with operation?
Chest is negative, abdomen is negative, but she's in shock without any response. It's a good thing to go to the OR. In the OR, I definitely would like to cannulate the iliac arch and to perform under the surgery and angiography. It's not a a fast exam, but I would like to know where is the leakage and stop the bleeding. Of course, if I'm inside the abdomen, because we don't have riboa, so it's not exist in Hungary, I can cross clamp the aorta from the abdomen, and after I have time to thinking where is the leakage and find it selectively inside the OR. Because another thing is the pelvic vein are small and they're everywhere. And if we see this C3 type fracture, it's a fact, it's destroyed. And it's not a one big lumen bleeding. It can bleed from the vein plex, and it can bleed, of course, from the spongiosal bone. And to stop this, I need a reduction. That's my opinion. So I need to figure out where is bleeding, and I need to do some bleeding stop procedure. If don't have other options in OR, just clamp the aorta arch.
Dr. Diaz, what would be your sequence of events? You're going to take this patient to the operating room. Any ideas? Obviously, it seems like orthopedics needs to be involved, vascular surgery, trauma vascular, depending on your institution. But what would you think in this would be the sequence of events moving forward, assuming as we think that the abdomen and the chest are negative?
Sure. So one of the things, just before I kind of go through the list, one of the things that it would be concerning, assuming that you were able to get a perfusing blood pressure, and if the area of amputation is not bleeding, that would be concerning for potential an arterial injury in the groin somewhere with this kind of injury. The other is, we talk about operations for pelvic fractures for hemorrhage control. This patient has an open pelvic fracture. So you may need to either close that wound real quickly to be able to obtain hemostasis to tamponade effect, and then decide how you're going to stabilize the pelvis. Before we did angioembolization and had CTAs for all the bleeding, what we did and what our other colleagues in the military would do is you would open the pelvis and look for the hypogastrics. And in this scenario, under this circumstance, I might be convinced that I would need to ligate the right hypogastric artery to be able to get hemorrhage control, which would be the only thing that you could possibly do. Doing an arteriogram, I think it's a potential option. How effective that is, plus it's not like we're going to be able to do an embolization in that scenario. Pelvic packing, it's kind of hard to pack a pelvis that has a hole on the opposite side in this scenario. So again, you got to go back and decide what you're going to do with the open wound before you're going to pack from the front. So it's a complex series of events. In the photograph that's shown, you kind of have to roll the patient to get to the posterior aspect. You're going to have to pack that somehow, probably with some degree of whether it's quick clot or equivalent type packing for hemorrhage control, and then maybe potentially having to oversew it and then decide whether or not you're going to go into the abdomen, into the pelvis, and try to either ligate some major vessel in the event that you have a major bleeding, or identify a major venous bleeding as described. But in that situation, you're going to open up the pelvic tamponade, which could be bad.
Dr. Martinez, there is some controversy out there about empirically embolizing both sides in patients that might have sort of significant injuries but not actively bleeding on angiography. Any thoughts on unilateral versus bilateral, and whether it's worth doing it empirically? Maybe the vessel is in spasm, maybe not.
So I think the biggest factor, would be resuscitation. Once patients' hemodynamics have improved and they're adequately resuscitated, we would potentially start seeing where the bleeding is coming from, whether internally or externally, considering the degree of soft tissue injury, which could help guide some of that decision making. And if truly you're resuscitating and unable to keep resuscitation, then that tells you there's something like actively bleeding. I have actually personally seen the devastating consequences of bilateral internal iliac embolization, where a patient truly had necrosis of his glutes and pretty much his entire pelvis, which ultimately led to his demise from pelvic sepsis. In the advent and how much interventional radiology has progressed. And now I'm speaking to resource settings where you do have fancy interventional radiology, because if the patient's a non-responder, you're worried about bleeding that cannot be controlled otherwise, then doing something like gel foam embolization, which starts degrading itself in 48, 72 hours, then would be much more reasonable than empirically embolizing both sides with coil embolization or a glue component that will not degrade over time.
All right, Dr. Chung, share with us what you guys do.
Sure. So we enter the operating room, and we sort of, everything was happening in tandem. I should start by saying that, in that orthopedics was available immediately, quickly X-fixed the pelvis, and then right thereafter IR was involved. They cannulated the right side and shot this angiogram, as you can see, and they found that there was a complex pseudoaneurysm with a large vascular injury from the right external iliac artery, adjacent to a SI joint injury on that right side. And so they did embolize the right external iliac artery without empiric hypogastric artery embolization on that right side. Surgically, we ligated the left popliteal AT and PT arteries for hemostasis, and we explored and washed out the patient's right perineal and groin injury. Unfortunately, this patient developed abdominal compartment syndrome on the table. As you can see there, she received 73 blood products within her first 24 hours. And so we did perform a decompressive laparotomy at that index operation. And we did pack her from the inside as well. Her right-sided retroperitoneum did have some bleeding. And so, we left packs there. She had a little bit of a mesenteric injury, which was oversewed, but we left her open and brought her to our ICU. You want me to keep going, Dr. Ricarte? Or...
Dr. Story, any thoughts on this? Anything you would have done differently?
It's always an interesting thing. What is the preferred approach? To start it using the minimally invasive procedures, just an X-fix, and try the embolism, or open it. I'm not sure every time the minimal invasive is what we can choose. Of course, it depends on the time, so it's not the fastest procedure in my institution. And my question is, it was only an X-fix or together with an SI joint anti-shock screw? Because one of the most bleeding point next to the direct artery lesion is from the SI joint fracture side.
Yeah, they only performed an X-fix of the pelvis at that time.
In my practice, but we are different. So we use a 4-pin X-fix together with that one SI joint screw for more stability, and it's only a 5 minutes to put in under an X-ray percutaneously. So no extra exposure needed.
I have a question.
Mm-hmm.
So I guess the decision was made to sacrifice the entire right lower extremity
Right.
at the time of embolization, as opposed to take the patient to the operating room and put a shunt?
Yeah, so at that time, yes, that was the decision. That's a great question, because it definitely comes into play later. In fact, within the next 24 hours, when we took her back to the operating room. The concern was that on her initial angiogram, she had very attenuated reconstitution of the right profunda, as well as the SFA via collaterals. And so that's why the hypogastric wasn't embolized empirically on that side. And then just because you asked Dr. Diaz, the next day, we went back for a belly, and all that, and we did our due diligence in terms of EUA with making sure there's no vaginal injury. Flex sig was done as well. There was no rectal or colonic injury. we, of course, had no PT or DP pulse on the right foot. And we called our vascular surgeons in, and we reviewed the imaging with them that we had. And essentially, there was a very small atretic SFA on the right side and PFA, which sort of reconstituted a little bit. They tried to do a right groin cut down to find any vessel they could in terms of a typical major femoral vessel. However, they were unable to find one and identify it, and there was no above knee popliteal artery on that right side either, and there was no right-sided PT, and so they could not perform a bypass in this setting. And in looking through her hospital records, she had a history of a left coronary artery to right atrial fistula and coronary artery aneurysm, that required percutaneous coiling at 1 month when she was 1 month old, as well as 1 year old. And so our thought is that her the variation in her right lower extremity arterial system is because of damage likely secondary to when they use her arterial system for this percutaneous treatment of her cardiac coronary arterial anatomy when she was merely an infant. And so unfortunately, we had essentially lost our blood supply to our right lower extremity.
Dr. Diaz, any thoughts on that based on now the information we have available?
Well, I mean, obviously that is a challenge, because it's not like you started out with someone with you would think normal anatomy. But I think that's kind of the decision you have to make in this scenario. It's you're down to kind of a life over limb, and sometimes the limb is all the way up to the groin in this scenario. I think that's the decision you have to kind of live with, a decision that you made. The other is I would have probably recommended not to attempt at revascularizing a limb that's been ischemic for over 6 to 12 hours, because they usually end up losing the patient at that point.
Dr. Martinez, thoughts?
I have a question. Were there any post-operative completion images performed after the initial operation in a patient with such high speed and high burden of injury in the pelvis that was unrestrained? You can almost presume that there could be either head injury or something else that we are unaware of with the images that we have so far. And then that could also play into if a CTA was performed post-op, that could clue you into any of the pre-existing arterial anatomy, as Dr. Ontracht mentioned in the chat.
Yeah, so after our index procedure, we took her for a pan scan. She had stabilized enough for that. And that was the imaging that was reviewed prior to going back to the operating room, as well as in the operating room by our vascular surgery team when we were considering potential revascularization of her right lower extremity.
We only have 4 minutes, Dr. Chung, so share with us what the outcome of all this was.
Absolutely. So unfortunately, as you can see here, we eventually were able to get her abdomen closed. We had to put her on continuous dialysis for renal failure. And ultimately, she ended up with a left-sided AKA. We did do a completion right lower extremity angiogram, which had no blood flow to the gluteal muscles or distally, which unfortunately in this case, meant that we had no reconstructive options, even if we were to do a hip disc articulation. And so there was no skin coverage option. There was no reconstructive options at all for this patient. Our OR cultures from our grossly contaminated wounds, unfortunately, did grow mucor, mold, and obviously a polymicrobial infection ensued. The issue, one of the main issues was, this is a very young patient in her 20s, and she was completely neurologically intact. And so she understood everything that was going on with her. She, throughout all of her procedures, she was participating in her care and writing coherently to us, to her family. there was talk and planned transition to comfort measures for this patient. However, the patient was writing, to us, please don't extubate, please let me, fight this. Unfortunately, throughout the next few days, she became more and more hemodynamically unstable, unable to tolerate dressing changes. And with her continued deterioration, so did her neurologic status deteriorate. And the family eventually did make her, comfort measures only, and they withdrew support on hospital day 33, and she passed away. And so this case, ethically, I think was very challenging for us. You can see all of her injuries there. However, ultimately, it was sort of this altered anatomy that really made it difficult for us to have any definitive management to offer the patient, especially when it came to her right lower extremity that eventually, with that very large perineal gluteal wound, had no blood supply. And so it could not heal. We could not, no matter what antibiotics we threw at her, how many times we took her to the operating room, she was not going to heal. And so it was a very difficult case.
I'm going to give our experts 30 seconds each for final thoughts. Dr. Martinez, I'll start with you.
I just want to commend you for presenting a case that's not a grade save that we often see in these conferences, because we do see these devastating injuries. And I appreciate you bringing in a tough case that unfortunately did not have a great outcome. Needed a truly multidisciplinary approach.
Dr. Diaz.
I would also agree. It is hard to manage these, especially the young patients who can talk to you, recognizing that they have an injury that is not fixable. But I think recognizing and helping the team recognize when you reach a point that the current state of the art is not going to be able to help the patient. I think having the ability to communicate to the family and the patient to relay that information is critical.
Dr. Satori.
Yeah, it's a great challenging case. So it looks like the polytrauma is not a couple of different injuries together. It's a systematic disease. And after a big soft tissue trauma, it responds a huge anti-inflammatory answer. And of course, the patient is young, but her inflammatory response was too much to survive, and it could happen. It's real hard how to manage it, how to thinking, because the patient is dying. It's also challenging for the team, how to communicate to the family, and how to see we lost the patient. It's also a challenge from the physician side. Yeah.
All right.
Thanks for
Well, I
sharing.
want to thank everybody, our expert panelists, as well as our presenters for today. Kevin put in the chat the link for the CME credit, so please use that. And I'll end up with Dr. Intrak's PSA announcement, always wear a seatbelt. Thank you so much to everybody, and we'll see you next month.
Thank you all.
Thank you.
Thanks so much.